Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Okay? Now, what's happening in this image here? Ah, some sort of filling defect. Yeah, through this upper GI series. Okay. We're going to be discussing this and much more on this presentation on esophagus pathology. This is covered in your book, Medical School Pathology and Step 1 Review. Scan the QR code to get to the website with all the updated material. Now let's talk about esophagus pathology. Specific things that you must know include tracheoesophageal fistula, esophageal fistula in general, esophageal web, Zenker diverticulum, miliary Weiss syndrome, and esophageal varices, okay? All of that is fair game. But don't worry, we're going to make sure you know what you need to know. Now, a tracheoesophageal fistula is a congenital abnormality. There are many types, highly likely you won't be able to or need to know the specific type, but you should be aware that it's congenital. The most typical form of tracheoesophageal fistula has proximal esophageal atresia and a distal esophagus that emerges from the trachea. Symptoms, as you can imagine, of tracheoesophageal fistula include aspiration, polyhydramnios, vomiting, and abdominal distension. Here we have a figure from a radiograph utilizing oral contrast showing an H-type tracheoesophageal fistula in a newborn. Another condition that you must be aware of is an esophageal web. An esophageal web is a thin esophageal mucosa protrusion, most frequently in the upper esophagus. For example, you can see on the right imaging showing an esophageal web stenosis utilizing a barium swallow examination. Symptoms of esophageal web include dysphagia and coughing. There is increased risk of developing esophageal squamous cell carcinoma with esophageal webs. Plummer-Vinson syndrome is characterized by an esophageal web along with a beefy red tongue from atrophic glossitis and severe iron deficiency anemia. Would you expect that to be macrocytic or microcytic if given those two options? Right, microcytic, right? So here we have more imaging of an esophageal web stenosis in barium swallow from the frontal view. Can you see the web? Now we have an endoscopic image for all you future ENTs out there. You're going to be seeing a lot of this. Now let's move on to Zenker diverticulum. A Zenker diverticulum is a pharyngeal mucosa overgrowth caused by a muscle wall defect, i.e. a false diverticulum. Zenker diverticulum occurs at the intersection of the esophagus and the pharynx. It rises above the upper esophageal sphincter. Symptoms of Zenker diverticulum include dysphagia, obstruction, and halitosis. Here we have a lateral X-ray from a patient with Zenker's diverticulum. Can you see that? Now, this is very important. Mallory-Weiss syndrome. You will be asked about it. Mallory-Weiss syndrome is a partial longitudinal mucosal rupture at the GE junction, gastroesophageal junction, involving the mucosa. Mallory-Weiss syndrome is typically due to intense retching or intense vomiting. For example, some risk factors for Mallory-Weiss syndrome include vomiting after extreme alcohol consumption or vomiting with bulimia. Okay? Clinically, Mallory-Weiss syndrome presents with excruciating hematemesis. Mallory-Weiss syndrome is a risk factor for Boerhaave syndrome. Now here to the right, we can see a clot in the esophagus at the site of primary hemostasis. Okay? And this is actually endoscopic bleeding in the setting of Mallory-Weiss syndrome. Now keep in mind, Boerhaave syndrome is tied to Mallory-Weiss syndrome, right? But it's more severe. With Boerhaave syndrome, that occurs when a full thickness tear of the esophageal wall occurs. Boerhaave syndrome results in air in the mediastinum and subcutaneous emphysema. Now let's talk about esophageal varices. Esophageal varices are lower esophageal submucosal veins that are dilated, that develop as a result of portal hypertension. Now you remember your anatomy, right? Now, the left gastric vein often serves as the distal esophageal vein's conduit to the portal vein. The left gastric vein backs up into the esophageal vein in portal hypertension, causing the dilation, i.e. the varices, like what you can see here with this gastroscopy showing esophageal varices with prominent red wale spots. And here's more imaging of esophageal varices. Note the ulceration at the site of the banding that was performed. Now keep in mind that clinically, esophageal varices are typically symptomless, but there is the possibility of rupture. Ruptured esophageal varices have a painless hematemesis at onset, i.e. painless, keyword painless, unlike Mallory-Weiss, unlike Boerhaave syndrome. Esophageal varices that are ruptured are painless. And here we have more endoscopy of esophageal varices, okay? You can even see them on x-ray. Note the snake-like varicose veins in the esophagus, secondary to pulmonary hypertension. Now let's move along to esophageal cancer, okay? Esophageal cancer appears later in life and has typically a poor prognosis. Symptoms of esophageal cancer include progressive dysphagia, weight gain, discomfort, and hematemesis. And they could actually have weight loss too. It depends, right? If they're not eating enough in the setting of esophageal cancer, they may actually lose weight. Additionally, cough and hoarse voice may be present due to the recurrent laryngeal nerve being involved. Esophageal cancer is usually squamous cell carcinoma, by the way. With this, the squamous cells proliferate malignantly. Squamous cell carcinoma, as we know, is the world's most prevalent type of esophageal cancer. Esophageal squamous cell carcinoma occurs most frequently in the upper or middle portion of the esophagus. Major risk factors for squamous cell carcinoma of the esophagus include tobacco smoking, or just tobacco use in general, right? Do people still chew? Alcohol consumption, even strong tea, right? Achalasia, digestive webs like Plummer-Vinson syndrome, or esophageal damage, such as that due to lye ingestion. The level of the esophagus that is affected determines the location of the lymph node spread. For example, if it's the upper 1/3, that will usually spread to the cervical nodes. If it's the middle 1/3, then that will usually spread to the mediastinal or tracheobronchial nodes. And if it's the lower 1/3 of the esophagus that's affected by the cancer, that will likely metastasize to the celiac or gastric lymph nodes. And with that, we're all done with this presentation. Congrats to you. You're killing it. You're doing a great job. You're making me proud. You're making your family proud. You're making your friends and family proud. You're helping them. You're sharing the knowledge. You're learning the knowledge. You're tucking it away. You're remembering everything because you know it's all tied together, not just for the examination or your current coursework, but you're going to be asked this so frequently in the near future as a resident, as a fellow, as an attending, from your patients, from your family. It never stops. So just remember everything. Okay? I'll see you soon.